So, unique and cost-effective organism-based endophthalmitis prophylaxis in community eye care section. So, the aim of the study was to analyze the outcomes of different endophthalmitis prophylactic measures in cataract surgery between the years 2013 and 2021 in a community eye care section of a tertiary eye care hospital. This was a single-center retrospective study. So, all the patients who underwent cataract surgery in the community eye care section from 2013 to 2021 were included in the study. Combined procedures such as trabeculectomy or penetrating keratoplasty with cataract surgery were excluded. The data was obtained from the patient records. All patients underwent detailed eye examination with an AK as well as A scan preoperatively, and sac syringing was done whenever indicated. Preoperatively, the periocular area and conjunctival sac was prepared using topical povidone iodine solution, and majority of the cases were done using manual SICS, which is 85.1%, and the rest by phacoemulsification with implantation of a PMMA IOL. The surgeries were performed by consultants, registrars, fellows, as well as postgraduate residents, and the same sterilization techniques were adopted throughout the entire study. So from 2013 to 2015, the endophthalmitis prophylactic measure which was followed was tobramycin 0.1 ml in 500 milligrams of BSS. In 2015 to 2017, intracameral preservative-free moxifloxacin was used. From 2017 to 2021, 0.1 ml of amikacin 12.5%, which was added to every 500 milligrams of BSS was used, thereby achieving an effective concentration of 0.025%. So here, the dose of amikacin was based on calculations which was targeting an anterior chamber concentration of amikacin that would exceed the MIC of the susceptible bacteria. Here you can see 0.1 of amikacin withdrawn and injected into the 500 ml of BSS. So postoperatively on POD1, the eye patch was removed and replaced with goggles. A complete examination was done and patients were started on ofloxacin dexamethasone, which was tapered over 50 days. So we analyzed the records of patients diagnosed with postoperative endophthalmitis or sectional wound infiltrates presenting up to 8 weeks postoperatively. All patients underwent detailed microbiological examination. Statistics was done using the chi-square test. So coming on to the results, we divided them into 3 groups. The first group, which is the tobramycin group, around 15 cases of endophthalmitis were reported. The second being the moxifloxacin group, around 17 cases of endophthalmitis were reported. And the third one being the BSS with the amikacin group, around 10 cases of endophthalmitis was reported. A total overall of around 240,000 cataract surgeries were performed during the study period. So among the tobramycin group, among the 70,000 cases, 15 cases at postoperative endophthalmitis, where majority was culture negative, followed by gram-positive cocci, nocardia, as well as fungal infections. In intracameral moxifloxacin group, 17 cases of post-op endophthalmitis were reported. Majority again was culture negative, followed by gram-positive cocci as well as nocardia. Third, in the amikacin and BSS group, though 113,000 surgeries were performed, only 10 cases of postoperative endophthalmitis were reported, and culture negativity was 80%, followed by gram-positive cocci. So on comparison between the endophthalmitis rate of 3 groups, after introduction of amikacin, there was a significant reduction in the rate of endophthalmitis. Here you can see the p-value which is being significant on comparing the amikacin group with the toba group, as well as I'm comparing the amikacin group with the moxifloxacin group. On coming on to the microbiological analysis, there was no significant difference in the rates of culture negativity or gram-positive cocci among the 3 groups. However, there was a significant reduction in nocardia endophthalmitis in group 3 on comparison with the other groups. So here you can see gram stain, the beaded pattern on gram stain for nocardia, as well as sectional wound infiltrates with hyperpion seen in these post-op patients. So among the endophthalmitis cases, 14 cases had been performed by consultants and 14 each by residents and fellows, and only 1 of the 42 cases had undergone phacoemulsification and rest by scleral MSICS, and only 2 of the 43 cases of endophthalmitis had intraoperative complications, one being PCR and the other being a ZE with vitreous loss. Coming on to discussion, we all know the landmark study, which is the EVS study, which stated that gram-positive cocci was the most common organism. Lundstrom et al. Also did a comparative analysis and found that gram-positive bacteria are more common when there was a communication with the vitreous, and gram-negative was more common in elderly patients. So keeping all this into consideration, the ACRS put down a guidelines of saying use intracameral cefuroxime 1 milligram in 0.1 ml. However, then we had the landmark trial by Haripriya et al., where they showed that the use of intracameral moxifloxacin brought down the endophthalmitis rate by almost 4-fold. But moving on to the literature review and seeing the causative organisms of endophthalmitis in India, you can see that the slow shift from gram-positive cocci to gram-negative organisms, as well as an increase in the nocardia species, especially in the south of India. So Prajna et al. Did the study and they found there was a high prevalence of nocardia endophthalmitis. However, they failed to find a solution for the same. So the microbiology of endophthalmitis in India is different from the ones reported in the EVS as well as the ESCRS studies. And latest studies have also shown that the irrigating solutions used intraoperatively were found to be the most common source of endophthalmitis. So use of amikacin in BSS could be an option when nocardia endophthalmitis is predominant. So amikacin, as we all know, it has good activity against gram-negative bacilli, against Acinetobacter as well as Pseudomonas, and it has got very good activity against nocardia and some mycobacterium species. So what about the safety? So with this particular dose of amikacin, it was reported to have no endothelial toxicity or no macular toxicity, as evidenced on specular microscopy as well as OCT macula. And coming on to cost effectivity, one vial of amikacin cost only 35 rupees. So one vial of amikacin can be used for 20 bottles of BSS. Therefore, in a community eye care section, it becomes very cost effective. So conclusion, this is the first and the largest single center study to report comparative analysis of different endophthalmic prophylactic measures in a community eye care setup with high incidence of nocardia endophthalmitis. Introduction of amikacin in BSS is thus a unique, cost-effective and efficient prophylactic measure to prevent nocardia endophthalmitis. These are my references. Thank you.
Thank you. Thank you, sir.
Thank you, sir.
Good presentation. Thank you, sir. Now Dr. Suraj Singh is on the way. Once he comes, he has to inform. Other person is Dr. Karthik. Karthik, yeah, please. And after Dr. Karthik, Dr. Ahmed. And then if Dr. Suraj Singh comes, he will also be taken if he comes before 9:50.
Good morning, everyone. My topic is on telemedicine and neuro-ophthalmology. Telehealth is the use of technologies for long-distance clinical care, health-related education, public health and health administration. Telemedicine is a subset of telehealth, which delivers remote patient care through two-way communication between the patient and healthcare provider through telecommunication technology. The revolution in information technology has made a positive impact in medical field where accessibility is a major problem. Many of the trained ophthalmologists are based in urban areas, catering to just 10 to 15% of population requiring such services. Majority of our population, 80%, resides in rural areas which have very little or no access to tertiary eye care. Teleophthalmology is a techno-savvy method where medical facility is taken to rural and remote areas by using computers, video conferencing and internet. It was very useful during COVID-19, which warranted social distancing. Vision centers provide primary eye care services with the help of trained ophthalmic technician at an affordable cost. It is connected with the base hospital through internet services to enable direct patient consultation and interaction with the ophthalmologist. Eye care services are accessible and affordable by reducing travel cost and time for the patients. And patients who need further evaluation and treatment at specialty services are referred to the base hospital. So neuro-ophthalmology involves diagnosis of vision-threatening and potentially life-threatening diseases where delay in diagnosis or treatment can be devastating. Teleophthalmology helps in picking up patients who need urgent and timely intervention. We aim to study the effectiveness of telemedicine in neuro-ophthalmology. It was a retrospective observational study. We analyzed data of patients referred from 13 primary vision centers in rural areas to neuro-ophthalmology services at Aravind Eye Hospital, Coimbatore, over 18 months from January 21 to June 2022. Clinical and demographic profile, diagnosis, time between referral and reaching base hospital were analyzed. Total of 335 patients were referred from vision centers to base hospital. Out of them, 88% reached the base hospital and 71% needed neuro-ophthalmic management. 59% of them were males, and the major diagnoses were cranial nerve palsy, which was maximum, followed by cerebrovascular accident, papillary edema, optic neuritis, non-arthritic anterior ischemic optic neuropathy, ocular myasthenia, and traumatic optic neuropathy. Other diagnoses were primary optic atrophy, secondary optic atrophy, nutritional optic disc failure, and toxic optic neuropathy. And majority of patients, around 50% of them, reached base hospital within 1 to 3 days of referral. And the main presenting complaints were defective vision, double vision, drooping of lids, field defect, headache, and eye pain. The clinical findings based on which patients were referred were extraocular movement restriction, ptosis, pupil abnormalities, and disc abnormalities like disc edema or disc pallor. Among 65 patients who presented with cranial nerve palsies, maximum were 6 nerve palsy, followed by third, fourth nerve palsy, lower motor neuron facial nerve palsy, and multiple cranial nerve palsies. Out of 27 patients who presented with CVA, 20 patients presented with field defect, 5 with cortical blindness, and 2 with vertical gaze palsy. Out of 46 patients who presented with sudden onset defective vision and RAPD, 15 patients had optic neuritis. 20 patients presenting with headache, transient obscuration of vision, and bilateral disc edema had papillary edema, and 2 patients had intracranial space occupying lesion, and 10 patients presenting with drooping of eyelids and or intermittent double vision were diagnosed to have ocular myasthenia. Toxic optic neuropathy was found in 8 patients, out of which 4 were tobacco alcohol induced and 4 were ethambutol induced optic neuropathy. All of them were evaluated and treated accordingly. Heather-Moss et al. Study surveyed 135 practicing neuro-ophthalmologists in US, comparing the telehealth utilization during pre-COVID, early pandemic, and 1 year later. 1 year into the pandemic, neuro-ophthalmologists still maintain telemedicine utilization at rates higher than pre-pandemic levels. They found confrontation, visual fields, ocular alignment, and pupil examination were not suitable for teleconsultation, but it improved access to care, continuity of care to the patient. Telemedicine has been proven to be cost-effective, accurate, and reliable method for screening and monitoring in patients with ROP and diabetic retinopathy. Teleneuro-ophthalmology can be used for follow-up of idiopathic intracranial hypertension, migraine, optic neuritis, and anterior ischemic optic neuropathy after initial evaluation and treatment. It will help patients in remote areas to access high-quality, cost-effective neuro-ophthalmic care. It will be useful in triage, diagnostic consultation, and long-term treatment monitoring. It is an important alternative for elderly, immunocompromised, and mobility-challenged patients. The essentials for teleneuro-ophthalmic care are best-corrected visual acuity, color vision, central fields by Jerem screen, pupillary examination with swinging flashlight test, fundus examination with a high-quality fundus photo. Pupillometer, Humphrey Visual Field Analyzer, and OCT can be incorporated in future for furthermore evaluation. So telehealth is increasingly recognized, and teleophthalmology does not substitute but supplements and complements in-person neuro-ophthalmic care. Many advantages has been explored during the pandemic, and it will continue to serve the rural population. It is an excellent tool in triaging patients and to sensitize them to get immediate medical attention who are otherwise reluctant to visit a hospital. So it is very helpful in neuro-ophthalmology services where timely diagnosis and intervention is very important, which will be vision and sometimes life-saving. Thank you. These are my references.
Thank you. I think nice presentation. Teleophthalmology is need of the day, and definitely artificial intelligence is again coming up. Whether it will be useful or not, or double-edged sword, we never know, because it shouldn't replace the human being. And
Yes.
then so many things like complicated things may be there, like somebody can post on your behalf some video, some audio, never know. So let's go forward. Teleophthalmology is need of the hour. I think you are connected very well with that neuro-ophthalm.
Yes, sir.
Nice, good. So,
AI in the current context is going on the negative side again. But then finally, we also need to understand, because there are a lot of youngsters, where I would like to put that nothing, only that AI works because the human connectivity is getting lost. So try to get connected with the patient. Everything, not that everything is possible with the AI. The human brains, maybe another 50 years, we are not sure. By the time, I hope I may not be there, and you are also not there after 50 more years.
I think most of the things we have created trouble for ourselves, like the surgical skill. We are telling to patients that machine will be doing, this machine is very costly. So the cost of the surgery is more. Robotic surgery has come. So people have started thinking probably surgeon is not going to do the surgery, it is a robot which is doing. So maybe the thing can come in the minds of people, like you can just stand on one machine and the diagnosis will be there, or sit in the machine and the treatment will be given. Like that. All those are of course fantasies. So human element should not miss. So it is direct patient and doctor relationship, that personal touch which matters. chair time has to be there. Don't feel that you have got so many machineries and you're treating the patient in a nice way with high-tech technology. That is not going to serve the purpose. The patient connect should not be missed, and that is the basic thing. And human doctors, the human brain, should also be correlated in medical treatment in future also. That should be our aim. Thanks.
Thank you, sir.
So the next presenter is Dr. Ramya, and after that.
Good morning, everyone, respected judges and my dear colleagues. In keeping with the Go Green initiative of the AIOS, I, Dr. Ramya Nadik, consider it my privilege to present today my paper on global warming impact of fluorinated gases in ophthalmic surgeries at a tertiary eye care center of India. This paper has been co-authored by my mentor, Dr. Rajiv Raman sir, and we have no financial interest. Global warming, as we all know, is the greatest health threat of this century. The healthcare sector carbon footprint accounts for 4.4% of global greenhouse gas emissions. Operating theaters are considered as resource-intensive areas and necessary for high-quality care. Hence, their environmental effects are not given adequate attention, and it is time for us to embark on the path of greener healthcare practices. This is a retrospective study spanning for 5 years, held at a tertiary eye care facility in South India. Since the procedures were completed prior to the inclusion, it was exempted from ethical approval. The aim of the study was to report the environmental impact of fluorinated gases used for intraocular tamponade procedures. The data was acquired from electronic records, operation theatre database, and store inventory. Procedures involving the fluorinated gases were included in the study, and those using air tamponade or silicone oil were excluded. The gas used for tamponade was as per the discretion of the surgeon, and the dilution as per the case requirement. The environmental impact calculations were done based on a calculator developed by Musa et al., which converted the volume of the gas to its mass by modified ideal gas law formula at the standard temperature and pressure for the canister. It was then converted to their equivalent amount of carbon dioxide in the atmosphere. Due to the variations in the canister pressure and atmospheric pressure, mass was used as a metric to permit comparisons because it is constant regardless of gas pressure and temperature. Coming to the global warming potential, we calculated the global warming potential for these fluorinated gases. Global warming potential is nothing but the amount of heat a gas absorbs in relation to carbon dioxide over time. So different gases have different atmospheric lifetimes, and fluorinated gases have several thousand years of atmospheric lifetimes, which makes their global warming potential significantly high as the time increases. We have used GWP 100 or global warming potential of over 100 years in our study. The results were tabulated, and we found that 1.4 metric tons of carbon equivalent mass was generated out of 1842 procedures that were carried out. Although most of the procedures did use C3F8 and only 24.37 procedures used SF6, it produced more than 50% of our carbon emissions. The most common indication for surgeries using fluorinated gases was macular hole surgeries, and even in these surgeries, most of the procedures did use C3F8. Comparing scenarios, if a single fluorinated gases was used in all of the procedures in the study period, we found that we could increase our carbon emission by almost twice if only SF6 was used, and we could have decreased it considerably if only C3F8 was used in all procedures. This study assessed the carbon equivalent mass for various fluorinated gases and suggested the possibility of global warming in the next 100 years. Similar studies have been done in UK, but this is first of its kind to be conducted in India. The environmental impact of fluorinated gas in ophthalmic surgery has received very little attention because of the limited intraocular volume employed. But the carbon emission is substantially more than anticipated because of the high GWP value. Although SF6 was used in only 24% of the cases, it resulted in more than 50% of our carbon emission. Therefore, we can consider using air tamponade more frequently as an alternative when clinically safe to do so. There have been reports that produce comparable surgical results with air tamponade as well. Additional research can be done for employing C2F6 at lower concentrations as well. Giving perspective to our study, we compared our carbon emissions to day-to-day activities and found that driving a diesel car for 6,000 miles or using an electric heater for 6 hours a day for a year would produce the same amount of carbon emission in the last 5 years that we have produced. To offset this would be a simple afforestation drive using 14 trees per year for 100 years to offset 14,000 kgs of carbon emissions that we have produced. The limitation of the study was we did not measure the carbon footprint related to production, delivery, storage, removal, or disposal of these canisters. However, it is a pioneer study in identifying the problem statement, directs towards designing protocols on usage of air as a preferred agent for short-term tamponade, and also motivates medical facilities to devise strategies to make healthcare practices greener. Thank you.
Good presentation again.
Thank
there
you,
was
sir.
one more presenter on almost the same lines.
Yes, sir.
So nice study, what you have done.
Thank you,
So
sir.
again, as Dr. Ambedkar sir has said, that it's possible where the space is available,
Yes, sir.
and for the bigger hospitals where the acres of land is available, and that particular model really has worked well. That's what we have observed. But let's maintain it in the bigger cities and metros where less space is available. Maybe government, again, previously I have said that there are government rules and regulations. We are trying to trouble our hospitals to have many more regulations and rules so that we cannot fulfill all those. And it's very difficult to run small size hospitals, medium size hospitals in various cities now. So daycare center that way is the option, but which is not given by many more states in India, because there is no special entity as daycare center. It is only clinics or hospital, no entity in between like daycare center. So I've been asking this particular entity as special category in various states. If they give that daycare center facility and that special registration, if it is provided, which can be benefited for our specialty or ophthalmology maternity, so that most of us can manage that daycare center, like do the surgery or do the procedure and send the patient home. Thank you.
Thank you,
very
sir.
much.
Suraj Singh has reached or not yet?
We will wait for some
I think we need to wait, but
because
then
the next session starts at 10. So the
9:50.
person is just on the way. If he comes, we will take him and justice can be given to him. Otherwise, the podium will be vacated exactly at 9:51.
Yeah, but then meantime we have some time to discuss. I would like to especially mention Dr. Basumati, because most of the data which was, no, I can have a seat, nothing very good. I just want to appreciate you for a reason that there are few presenters, those who are present in the audience as of now also, few have left already. But then I think whatever presentation she has done for the data, most of the people have done the data presentation as just gist, while that was something different what she has done in various forms and associated with the actual procedures and everything. So her slides were, I appreciate her presentation, the flow as I because I have some time. So just people are sitting here. So there are few juniors also. I'm seeing them. So I think next our conference we should think of having another session of how to make the PowerPoint presentations more effective. I think that would be another good interesting subject for you, because your presentation was very nice. And another thing that probably again getting back, for the both of us are on the same generation, but then in your generation people are looking for most of the things through the AI. I go back to my this thing. Are you Dr. Suraj Singh? Okay. No, because we are just waiting. It is like, in IPL, if the next batsman doesn't come within 90 seconds, then automatically he is not eligible to come. But he has got a time till 9:55, another 7-8 minutes more. So for the juniors, as I'm getting back on this, is that looking at the current scenario where we are more with the social media and other things, but finally on a long-term basis, we are not in the manufacturing sector. Suraj Singh?
Yeah,
So please come.
upload your presentation. Relax. We'll give you 2 to 3 minutes just to
So by the time he uploads, so that the last visitor is also here now.
relax, and then you can present. In between, if you have got some points to discuss, we'll discuss till he starts his presentation.
So we are not from the manufacturing sector, we are dealing with the human beings. And there is a mind in everybody's person as a human being. So try to understand the other side of the story also always. Like you are an eye surgeon. Suppose your parents or someone known to you gets any heart problem or any brain problem or anything, where the bypass or no bypass or whatever may be the case. You are as bad as a lay person, though you know general medicine as such as an MBBS doctor, but then you are not technically aware about the very fine intricacies. So you may not be knowing that what is going to happen, what is on pump, what is off pump, whether off pump is possible, on pump is dire necessity, and so on. So effectively, you will also have the same questions that are there in the mind of a common person. So whenever you always explain to a patient or their relatives, see that your communication is good enough, confident enough, and always people are thinking that itne time mein itne patient hona chahiye. I think that cannot be the way. Finally somebody may have, I don't say that you should entertain Google Baba, because people nowadays are coming with Google Baba ki sir usme aisa likha hai waisa likha hai, but I always make it a point that better to ask Google is first. Second is what Google gives is information, and it is not the knowledge. You have to use your wisdom to convert that information into knowledge. So try to make the relatives or the patient understand, even if it's through Google Baba, that whatever you have received is merely the information. So never ever use this at a wrong place, and don't try to teach us. I am very blunt probably at my age I can be that absolutely blunt with saying that you better consult Google only and need not come back to me at all. So that's not an issue. But then as a beginner, you may not be able to be that rude with the patient. But always remember that making them to understand in a polite way and a proper tone of a difference between the information and knowledge. Like everything is available. How to make atom bomb is available. How to make a car, even BMW, Mercedes, or anything, you can see it on YouTube. You may get everything available from the vendors, but you cannot make the same car as the BMW original company manufactures. So similar way, you make understand it is ready to go. Fine, I back out. And
before that, what sir has said, how to prepare atom bomb. Don't do that. How to prepare the bomb. If you just the moment you search, you are taken to police. It is that way. It is very serious. Google is very serious. If you try to search how to prepare the bomb, it is traced, and police come to your place, or they are tracing the person who is putting that in search. These 2 to 3 things they are there. That's why if you search on Google, you are gone.
instead of making the atom bomb, I started making Mercedes or BMW.
Before he starts, I must say that what sir has said,
sure.
that most of the times we are at fault. We are telling to our patients that this surgery is only within 5 minutes. Then you can go home while driving your own car. It is very simple. So what patients feel that if the surgery is so simple, within 5 minutes, why are you charging so much? And if there are no results, if there are some complications, again patients are troubling you a lot. If you take more than 5-10 minutes for your surgery, what you have promised, suppose there are some complications and you have tackled in a nice way, and if 1 hour is gone, patient will not feel that you have done the nice thing. What they will say, why there was so much of time taken, why there was some complication, and why you took more time. So that goes against you. So telling so many promises, giving so many promises to patients and relatives is going against us. So all these things one more time to tell our patients and relatives is boomeranging. So be careful, explain everything in a nice way. It is not the simple surgery, that's what you have to tell. But we are telling that it is very simple, but then cost is not comparable. So it is simple for the skilled surgeon. So it is a skill what you have. But suppose the complication is there, suppose the patient is complicated, that particular scenario is complicated, you are going to tackle the thing. In that case, though you are doing it in a nice way, it doesn't remain simple from patient's perspective, from the relative's perspective. So you have to be careful.
That I have got a standard sentence to say that you want to look in the time or you want to have a good surgery. So 5-7 minutes here and there doesn't make any difference. But be particular to have a good surgery. सर वो मेरा पिछला ऑपरेशन 5 मिनट में हुआ था, दूसरे को अभी 10-12 मिनट लग गया. ठीक है, एक ही हाथ की 5 उंगली सेम नहीं होती है. So same as that, you have to find some simile, so which will pacify the patient. Are you ready? I'm just killing the time, because finally it is like कोई पॉलिटिकल सभा जैसी होती है कि वो मेन बात करने से पहले जैसे लोग बोलते हैं. Good to go.
So, thank you, sir, and other colleague, and for this opportunity as well. So, today I'm making interest. So, anyway, the purpose of my talk for today is like I want that all the professionals working in the ophthalmic sciences, it's time to know what is all about assistive technology for visual impairments. So the managing low vision in a blind, so it's time to know what is assistive technology for visual impairments. Because that, as you know that people with suffering from low vision and blindness, there's no other means to cure the disease. So that the ultimate goal is how to manage those people suffering from low vision and total blind. So with the help of assistive technology, this is all about a model that we developed, which support from WHO. This is improving access to assistive technology for visual impairment in Delhi, the school-based model. So coming to the assistive technology, so first we should know the assistive product. Assistive product is a simple product which can enhance the function of the human. Suppose, for example, someone is having difficulty in seeing, so wearing simple spectacles, so spectacle becomes assistive product. So it can be software, it can be hardware. So when you say the assistive technology, so it means the product means the related system. The related system means you have to assess, you have to prescribe, you are recommended, or then give a training how to use it, okay, over time. So this is the assistive product and assistive technology. So assistive technology is something like, it's not to be treat or cure the disease. Okay, this is a simple product to be used by a person suffering from some form of limitation. This is all about assistive product. So these are simple assistive product from the high end to the low end to the high end. So you have the magnifier, you have the large keyboard, and the embossed math, and so many assistive products, talking, calculator, science and math assistive product, and braille, USB recorder. And other one is a very high end, in terms of thousands of dollars. So coming to the background, so as you know, the assistive technology for students, for visual impairment helps students in terms of improving their academic skills, non-academic skills, and their independent living skills, social inclusion and participation, and also problem-solving skills. So there are so many benefits about assistive technology. And despite the well-known benefits, what is happening is the poor availability of assistive technology for visual impairment in school for blind in Delhi. Maybe other part of the state also. And a study reported 11 out of the 52 device assistive product. So in 6 out of 10 schools are present. But when you come into the braille, slate, and the stylus, so there is only 9 out of 10 schools are available. So that means that majority of the assistive product for visual impairments are not available in the school for blind in Delhi. So, and at the same time, very few trainers about assistive products in schools for the blind. And this is a quick, survey we did it. So here you will see that this is a classification of the assistive visual impairment. So we did it, that we classified this this is related to the my presentation, that's why I saw. So this is the objective to design a school-based model to improve access to assistive product in schools and identify the types of ocular mobility and among students. The primary objective, our focus is the primary objective, how to develop, how to start this assistive technology training in schools. This is very challenging. For that, so we, out of the 24 blind school in Delhi, so we identify 2 schools. One is girls' school for the blind, another one is boys' school for the blind. So it is very challenging. So it's very difficult to convince the principal and the secretary. So they don't know what is the assistive product, these new things we don't know, so we are not interested. So we repeatedly talk with them, principal and secretary. We had a meeting a couple of times, and finally, so we became successful. Then we were able to convince the teachers. Then luckily they provide a dedicated room for assistive technology for visual impairment training for the students. So these are 2 schools for the blind. As you know, there are 25 schools in Delhi. So we have selected 2 schools, and see for the training, we have a low vision team. Okay, so for a training assistive product, we divided into 2 different categories. One is the BAD, one is DEF. BAD means visual-based assistive product. There is your magnifier, large print book, CCTV, and those are the visual-based. And second one is the visual substitutions. That is tactile and sound-based. There are so many products based on tactile and sound bases. So, for example, Desi book, sonic leveler, digital auto recorders, vector readers. So in the training, so these are the classification you see here, that visual loss range, WHO classification. For our purpose, we classify that visual impairment, low vision up to 160 and less than 160 blindness. And see in the other side, you'll see the this flow chart. So students, we triage into 2 different groups. The group 1 is the BCBA, the best corrective vision acuity, better than 160, and the group 2 is the best BCBA, less than 160. So accordingly, so category 1, category 2, just simple, using technique we can categorize in the school, so we don't have to go detailed examination. They have the certificate also. So we categorize it category 1, category 2 for education purpose. What sort of assistive device should be provided to training, and for orientation and mobility, we know that cane There are walking cane. So different types of walking cane. Because low vision person, they don't require the long walking cane. They just need a guide cane. Whenever they require, they use it. Otherwise, they should put it in the pockets, something like that. So as I said, so we classify the visual impairment. This is a well-known study. You will see here. So around 50% of the students in schools. So in the downstairs, around 50.6 students, DCBL better than 160. So they'll be needing some sort of visual-based product. Like you have magnifier, you have large print book, and so many associated product. And the near DCBA, 28.8%, so they will be requiring large print book. So this is a simple classification we did. And this is a training, so we started providing training, and the students, boys and girls, and for a training purpose, we need to divide in small groups. So we can give a large number of groups at the same time. Sometimes one-to-one training, yeah, small group, maybe 3 or maybe 2 students. So this is a training we provided, different this thing. And this is a training manual. Results, so far 100 students are being trained, boys and girls, and the device, walking cane, third-party special apps for the smartphone, and Desi player, digital access. This is this Desi player is like this reading material will be converted to the accessible software material. Then it will Desi player will play what is that in the content. And Victor Reader, Dot Mini, USB recorder. These are the accessible products we provide training. And this is the student. I just wanted to use last 2 slides. So this is the recording. See. Oh, boys.
To sum up.
Yeah, this is the last one.
ट्रेनिंग दी है अभी तक? आपने डीसी प्लेयर, विक्टा रीडर और स्मार्ट विजन ग्लासेस की ट्रेनिंग दी है।
अच्छा, इसमें डेजी प्लेयर जो है उसमें हम क्या करते हैं?
सर डीसी प्लेयर में हम रिकॉर्डिंग कर सकते हैं, और जैसे हम अगर स्कूल नहीं गए हैं और वो रिकॉर्डिंग करके हमारे लिए आए, उसके बाद हम उससे पढ़ाई कर सकते हैं।
अच्छा,
और लेक्चर भी रिकॉर्ड कर सकते हैं।
अच्छा,
इसमें वाईफाई भी कनेक्ट हो सकता है, और हम इसमें ई पुस्तकालय से भी बुक रीड कर सकते हैं।
अच्छा,
इसमें खुद की मेमोरी है, इस वजह से हमें अलग मेमोरी डालने की कोई ज़रूरत नहीं होती है।
आपको ये डिवाइस जो है कैसा लगा वो? आपको लगता है वो यूजफुल रहेगा आपके लिए?
यस सर, मुझे ये डिवाइस बहुत अच्छा लगा, और ये हमारे लिए बहुत यूजफुल है पढ़ाई के लिए।
अच्छा,
Okay, we'll go ahead.
मेरा नाम
So this is the smartphone. This kids. So
ऐसे नॉर्मल ऐप्स यूज करते थे।
अच्छा, उसके बाद हमने आपको यहाँ पे ट्रेनिंग दी है ना? तो आपको हमने ट्रेनिंग में आपको क्या क्या ऐप्स सिखाई है हमने?
आपसे मैं कोई रीडर, मनी कैश रीडर, इन सब ऐप्स।
अच्छा, इसमें इंस्टा रीडर में क्या करते हैं बताइए?
ऐसे नॉर्मल।
So the last conclusions, we know that a sizable number of students would be benefited with the visual based and other smartphone based apps. Students are interested to have the active training in the schools, so that what are available, advanced, even the advanced technique also. It is important that all students can access the appropriate assistive technology, and it's very important, let them aware right from the beginning, before go to the college level, university level, and before going to the PhD level. Because once they know at the very beginning, they will definitely help to in terms of employment and job. This is the way forward. Because this is another issue we found with the dental problem among the blind schools, and for the girls schools, girl students, that the menstrual problems, menstrual hygiene problems. We found it. But they don't know how to, like that's why we need to contact that ophthalmology, faculty or residents, so that some kind of accessible material for the girls blind school blind. Thank you so much.
Thank you. It was a nice presentation. So with this, I think we are coming to the end of the session. Dear friends, we started on time and we're finishing on time. We'll take the group photograph. The presenters who are present here, all of us, please come forward. Thank you so much. And we are handing over the session to the
Next team. But I think your topic was very interesting. Needs more elaboration. Unfortunately, you came too late.
Yeah, that's okay.